Hi, I'm Dr. Geoff Butler, and I've been a clinical educator for the last 20 years. What we're going to be trying to do is actually bring what's usually an in-person format of learning into the internet to sort of see if we can create cases that would be useful to the med student or the clinical clerk or the resident or even young associates, nurse practitioners, or just people who want to follow along with clinical cases. These will be question and answer based, so we'll bring up options on this side just so that people can play along with them and just sort of see the type of things that we go over on a daily basis reviewing clinical cases all the time. So today's clinical case is going to be a 45-year-old woman that you saw in clinic. She came in for a refill of her metoprolol. She is otherwise, healthy. She also takes Ventolin, which is an inhaler she takes for her asthma, and she's also on birth control. But beyond that, she relates no specific issues, and she's just here for a refill. So you've done her blood pressure, which came back at 130/80, and you're just coming back out to me to sort of say, hey, this is the case. Should I just refill it and let the patient go on their way? So first and foremost, what actually is metoprolol? So what class of drug is it? So if you guessed that metoprolol is a beta blocker, you would be absolutely correct. So that is certainly the case of what that function is. However, if you said it's a beta blocker and it's also a class 2 antiarrhythmic, you would be more correct. And that's important to sort of realize that oftentimes medications will have multiple functions and you should be aware of them and know why the patient's actually taking them. So knowing that now, the question becomes, well, how does the actual beta blocker work? What does it actually do? Well, the reality is, as its name entails, it actually blocks the beta receptor. And how many beta receptors are there? And we'll give you options beside again. And if you said 3, you would be absolutely correct. Back when I started training, there were only 2. I mean, obviously there were more, but the other subtype beta 3 wasn't recognized. So for all intents and purposes, what we deal with clinically, most importantly, while beta 3 is still important, is beta 1 and beta 2. Beta 1 refers to cardiac specific receptors, and beta 2 is more found in the lungs and other structures. And while that's important, especially to this clinical case, because this patient's on Ventolin, which is an inhaler for her asthma, if she was on something that wasn't beta 1 selective, it would be adversely affecting her asthma. To the point where when I was first training, we actually didn't use beta blockers at all in asthmatics, but now we can because there are beta 1 selective beta blockers. So metoprolol is a beta 1 selective beta blocker. Are there other ones potentially? This is something I would ask the residents, and obviously there are. So you could also have named bisoprolol, which is another beta 1 selective beta blocker, which is monocore, and atenolol, which is tenormin, is also one. Now that second name that I'm giving you, what is that? Every drug has a chemical name and it has a trade name. This can be very frustrating for frontline individuals because you should know both because patients will intermix them and you want to make sure that you know what they're dealing with. If I take this specific example, if this patient came in and her blood pressure wasn't well controlled, let's say it was 160/100 and you had to make an adjustment, if you don't recognize her medication list, you may add in a drug she's already taking and you want to avoid that at all causes. And in someone who works as I do on a border city, that can be very frustrating. So if I take metoprolol as an example, metoprolol, its chemical name we've stated, but its trade name is actually Lopressor. In the United States, it's also Lopressor, but it's also Toprol. So somebody can come across, they're only 10 kilometers away from us just over the way, and they're coming in telling you they're on Toprol, and you have to recognize that it's actually metoprolol. So having said that, we know that her blood pressure is well controlled and the resident can certainly ask, can I just give her her refill and let her go on her way? And you certainly could. But I always encourage residents, I think with every visit, with every treatment we sort of initiate, we should always be running things through the filter of the four most important parameters of health. And those general things are your mental well-being, your physical well-being, your diet, which includes things you ingest in general. So that's like alcohol, drugs, those type of things, and whether you smoke, and then your sleep pattern. If those 4 parameters are in check, if you are making an effort to work on them and they are doing well, you are going to avoid most medical issues that can potentially develop. It is the most important factors that we have to be addressing at all times. And sometimes we forget that. So when patients come in and they're being diagnosed with hypertension for the first time or high blood pressure for the first time, we should always be dealing with those aspects. And you can always quickly go through them. So in this particular case, you can run through, is this person, exercising on a regular basis? So how many times do hypertensive guidelines recommend people exercise on a weekly basis? The actual answer is 4 to 7 times per week for half an hour. So if she isn't, then you can encourage her as best you can. And always do this without judgment. So the point being is we're not here to judge people, make them feel bad. We're trying to maximize their health potential. We're trying to make them feel better. We want to feel like they can come back in. They're not going to disappoint us. We don't have an agenda. So we talk about the exercise aspect. If it gets into dietary aspects, you can talk about sodium intake should be less than 2 grams in a day. They should be sort of maintaining their BMI somewhere between 18.5 to 24.9. We can discuss that in another subset video. But in that discussion we're having with this particular patient, turns out she relates that she's actually a smoker. So that's something, and this is why we ask these questions, that we can then go down that path, again, if the patient is comfortable. So if the patient has no interest in smoking, she actually tells me, but you know what, she intervenes ahead of you actually saying anything, I love smoking. That's fine, as long as they know the risks, and we can talk about that when we go over specific smoking issues. We're not here to intervene. However, there are always opportunities to sort of introduce small aspects. And let's say you're getting the feeling that she wanted to potentially quit. She's giving you that energy where she would like to change things if she could. What do we know about smoking in general? So if I had to ask you, the actual resident, what's the increased likelihood of having a stroke if you actually smoke? What's the answer? And the answer is about 200% chance, more likelihood of having a stroke if you're actually a smoker. What about if we look at adverse cardiac events? What's the increased likelihood of having an adverse cardiac event if you smoke? And that number is 200 to 400% increase. So these are numbers you may choose to use, you may not. You don't have to use them in every specific visit. The ones that I find particularly useful is looking at the risk of all-cause mortality if you're actually a smoker. So if I look at that parameter, if you smoke 10 cigarettes a day, what's your risk of dying from all-cause mortality? And it actually doubles, or is 200% more likely if you're actually smoking 10 cigarettes per day. If that increases up to 25 cigarettes per day, it quadruples. So doing rough math, the one parameter that I do like to use when I'm counseling patients and the format seems appropriate, that essentially for every cigarette you smoke in a day, the risk of increasing death from all-cause mortality is 20% higher. And that's something that people can usually relate with. So I don't use that with every counseling visit, but it's something that I may want to use if the patient sort of seems somewhat interested but isn't quite convinced that it's something they should be doing. So let's say that patient then sort of says, well, what could I be doing to sort of help with that? And this is where that conversation becomes much more global. You can talk about, again, their physical exercise and what they're doing, health parameters and stress potentials come in. There's accessory aspects like hypnosis and those type of things, which are beneficial. The numbers, they're not as well studied to know what they specifically are, but the patient is interested. You should never shoot those things down. It's certainly something we can entertain. But let's look at the parameters that we know and have hard numbers for. So what about if we recommended for them that they use the gum or the patches? What's the likelihood that we increase their ability to quit? And that likelihood actually increases by 60%, which is actually fairly significant. And then if they want to progress to medication, so are there oral medications? And again, keep in mind, those are by no means the be-all end-all. But in this particular topic, we do know that they add significantly more likelihood that you can actually quit smoking. So there's two that we use here in Canada. There's Wellbutrin, which is bupropion, which Wellbutrin is the trade name we utilize when bupropion is utilized for depression. For smoking cessation, it's called Zyban. And there's another one which is called Champex. Champex is the actual trade name. The chemical name is varenicline. And those two increase the likelihood that you stop smoking by 300%. Now, those seem like big numbers, but if you're honest, what does that translate into in theory? So how many patients out of 5 are going to quit if they actually use those oral medications? And the answer is actually 1. So 1 in 5 will actually have a likelihood of stopping with those medications. And that's significant. You know, I don't want to make light about it, but you also want to be realistic with knowing what those numbers actually mean. But the biggest aspect, which is always the case, is the willingness of the patient to want to stop. So if you have a patient and they love smoking and they're not going to want to quit, then don't pressure them excessively. Just recognize that's the case. Try to give them a couple of pointers, and maybe they come back and see you in a few weeks. Maybe they don't. But that's where you want to be pushing things as best you can. Now, lastly, before we leave this actual topic, those of us who are astute will have also recognized that patient was on another medication, which is the birth control, which you cannot be taking if you also smoke and you're over the age of 35. It's actually an absolute contraindication. So this is an example of why we want to ask those additional questions, because it gives you an opportunity to pick up on things. And you can sit there and ask, well, how on earth could that possibly happen? How did nobody pick up on this? The reality is humans are fallible. You know, it might just be that her clinician didn't ask the question. Or potentially the clinician did ask the question, but the patient felt bashful and misrepresented and just didn't sort of bring that issue to the forefront. But now they're putting themselves at risk because smoking increases your clotting potential, and so does birth control. And those two, the likelihood of having a bad outcome from the standpoint of a DVT or a clot in your leg, or a PE or a pulmonary embolus or a clot in your lung, or God forbid a stroke, is actually quite high. And you want to take those opportunities, again, without judgment, tell the patient, really you should be stopping that medication. Now, you have no control as to whether that happens, but you have the opportunity to provide that patient with the information that this is potentially going to lead to a bad outcome, and give them that information and see how they do with it. Now, having said all of that, so once you complete that visit, you've talked about their general well-being. Certainly at this stage, you would refill their metoprolol, you would send them on their merry way, and then sort of see how we do in the next clinical case. All right? You take care.